Hello, my name is Christian Zilberberg, and I am the president of Junior Chamber International, JCI New York City. JCI is a 100 years old global organization present in 124 countries. Its members are young citizens, entrepreneurs, professionals, and community leaders that develop projects to bring a positive impact in their community. The issue that affects the world and our communities right now is coronavirus, COVID-19. That is why JCI New York City is starting a series of discussions with experts to understand better COVID-19's nature, its effects, and what can we do about it. Today we have with us Elodie Ghedin, Professor of Epidemiology, Biology, and Public Health at New York University, a world authority in the study of viruses. Her lab studies the influenza virus, the flu, its emergence, evolution, and transmission dynamics. This is relevant in the context of COVID-19 discussion because flu and coronavirus are often compared. To get us started, I will ask the first question. What are the main differences between coronavirus and the flu? And why people and governments are so much more scared of the coronavirus compared?
So a comparison between flu and coronavirus. So first, the reason, and I'll start by the modern era, which is now. The reason it's so important and why we're far more scared of coronavirus than flu is because it's a new emergence in the human population. So when a new virus jumps, when you have a cross-species jump, you basically have no immunity against this virus. So we're all considered susceptible. That means we all can catch it, we can all get sick. Now it's a virus that belongs to a family of respiratory viruses. The coronaviruses are actually, there are 4 that already exist in the human population and that we see during the winter month. So when you have a cold, flu-like symptoms or a small colds, it could simply be the coronavirus. We've seen coronaviruses circulating in the human population, but this one is more important. Basically, some people, as we know, can be have a very mild infection, and others can have a more severe response, a more severe disease. Now, how it compares to flu, well, flu, we know, kills a lot of people every year, but a lot of people in the population have some immunity against the flu. So not everyone catches the flu. And we also have vaccination against flu. So that also protects us in the population. It protects a lot of people. It protects populations or groups of individuals that are more at risk and that cannot get vaccinated, such as the immunocompromised, babies. But this corona, we have no vaccine and we have no real drugs to treat it. So although it's also an infection that a respiratory infection that is transmitted the same way that flu would be transmitted, it's far more important right now because the sheer number of people who can get infected.
So the second question that I'm concerned with is how did COVID-19 emerge? Or how the virus that created the COVID-19 or provokes COVID-19 emerge? There are a number of theories related to this. One is that it somehow got to us from bats. Another one it was engineered in a lab. What do you know about that, and how can we eliminate the false theories?
Okay, so we basically know where the virus came from. Bats are actually the origin of that virus. It was very well analyzed looking at the genomic information from the viruses that were isolated from infected individuals. And when you look at the genetic information, it really tells you where the virus comes from. And there have been a lot of viruses that were decoded, that were analyzed, coming from different animals, from bats. And if you look at the relationship, how closely they are associated, you see that the most common ancestor, so if you put the genome from the virus that was collected from people with COVID, you put it in what we call a phylogenetic tree. It's like a family tree, and it gives you the ancestry. And when you put in that tree the bat viruses and this COVID, so the SARS-CoV-2 is the name of the virus, and COVID-19 is the name of the disease caused by the virus. So when you put it in a tree, you see that the most common ancestor is actually a bat virus. Now, when people started looking at the sequence, at the information, it looked like it is really built to recognize human cells really well. And so it was thought, could it have been engineered? But in fact, when you look in nature, there are viruses that come from bats and that come from small mammals that could have acquired it from bats. It's identical. So it is a naturally occurring virus that has jumped into the human population. And as a virologist, we were completely not surprised when we heard about this outbreak, because it happens all the time that the viruses will emerge in that do a zoonotic jump, that will jump from from animals to humans, and primarily from bats.
But another question is, how can it jump from bats? Because I would understand if it jumps from, for instance, a dog or a cat, or for instance, even a mouse or some kind of other rodent, because we have them around. But how can it jump from a bat? Maybe I saw a bat a few times in my lifetime. But,
okay, so bats are special. Bats actually have a lot of viruses that don't make them sick. So they do have unique viruses that are in the family of the coronaviruses. And the coronaviruses specifically are viruses that jump, that can infect humans, not in all cases, but there are many cases. Now we saw in 2002, 2003, the original SARS. When we talk about the reason it's called SARS-CoV-2, it's because there was another SARS that was back in 2002, 2003. And that one was also from bats, and it had basically infected civet cats, and civet cats are actually a source of protein and are sold in markets in China. And MERS that emerged in 2014, about 2015, 2014, also came from bats, and it also emerged, we don't know exactly what the link was, but then it was found in camels. So MERS is the Middle Eastern Respiratory Syndrome, and it was from camels to humans, but the ancestor is bats. Now, bats exist everywhere, mostly in rural areas, and you find them in forests, and they tend to really lodge high up, and it can be, in barns, it can be in forests, and there is an encroachment in some parts of the world. There's a big encroachment of human populations into wildlife. And bats have a lot of droppings that can actually land on small mammals, and the small mammals are hunted for meat and sold in markets. And we find that in areas of China, and that's why often we see emergence of these new viruses in China. Does that answer your question more of where it comes from?
Yes. That answers my question. I mean, it's because it was a question that actually puzzled me quite a lot.
Just to continue with the comment you made that we are far more exposed to rats, to our dogs, and it's true that they have their own viruses. We don't really pass our viruses to dogs like they don't pass viruses to us. It does happen in some cases. There are flu viruses that are found in dogs or in horses, for example, but viruses are very specific in what cells they recognize. So they need to recognize a receptor on the cells of the host that they infect. And so we are constantly bombarded by viruses that really cannot infect us. We just, get hit with them, but they never are able to go into our cells and make copies of themselves and make us sick. So, there are viruses that you find in small, like in rodents, that can make us sick. And I think Hantavirus is one of those. I mean, there are a few viruses that can make you sick that come from small mammals.
Actually, that's a very interesting point that you've raised, because recently I was talking with a person, and that person told me that, oh, coronavirus, it's not the next issue is already coming. It's Hantavirus. And
Yeah.
he told me that, oh, China already has the first death cases. So we'll have coronavirus and Hantavirus. So what can you tell us about this? Should we be afraid already of the new virus?
So I don't think so. I haven't studied, Hantavirus. I don't even know how it's transmitted, but it's certainly not the way a respiratory virus like coronavirus. And I think Hantavirus does not have the long asymptomatic period where you may be carrying and not sick. And so I haven't looked into it specifically, because I heard, like you, that Hantavirus was a new outbreak in China right now. But we've seen Hantavirus before. It's not the first time. And it's usually more localized outbreaks. It's not, I'm not fearful that it will be another pandemic like coronavirus.
And I am also curious, with these measures that we have, the quarantine, the fact that the schools are closed, the fact that universities are closed, the fact that countries are closed, like Italy and many other countries are closing, like cities are closed. What will be the effect of all this closing on all other epidemics, on all other viruses?
Oh, that's a very good question, because it will probably reduce a lot of other infections that we see constantly during the season. So it is, right now we're finishing what would be the influenza season or the cold season in the northern hemisphere. And so all this distancing that we're doing is probably helping out with many other infectious diseases. But of course, the main reason we're doing it is to stop the spread of this infection, because the virus will eventually sort of burn itself out. And what we're trying to do is not provide the firewood for this fire, because that's what it is. And all of us, by being susceptible, we are the wood that maintains that fire going. So we just need to bring it down a bit.
So if we will bring down a bit coronavirus, it's possible that we'll bring down also the flu and maybe other epidemics.
Well, so it is helping control the flu epidemic. And before Corona hit, actually, this year was a very severe flu season. So there were a lot of people with flu. Now, right now, we're not sure whether a lot of these severe flu cases were actually COVID, which is possible. Very early on, we may not have realized that the severe cases of pneumonia, which we thought could have been flu, could have been corona. In many cases, they were diagnosed because they'll do a test to see if it's influenza. But we suspect that there are people who are getting mixed, both infections, are getting flu and coronavirus. So, once the fog of war is gone and we're able to analyze the data, so let's see in 6 months or in a year, we may be finding a whole new epidemiology, or finding a new sort of transmission pattern of all these other respiratory infections or other infections because of the distancing we're doing now. It'll be interesting to see what we observe.
That is actually fascinating, because yes, I was thinking that if we close everyone for 2 weeks, I mean, just everyone in the whole world, it's possible that coronavirus will disappear, flu will disappear, and maybe other diseases and infections will vanish.
So I highly doubt that flu will disappear, like I highly doubt this corona will disappear. And I'll tell you why. It's because they're super well adapted to us. And it's actually was surprising how well adapted this coronavirus is to us. How it, you know, when you're a good virus, when you're doing your job really well as a virus, what you want is to not make your host too sick so that your host can still go out, interact with others, because what the virus wants to do is spread itself. And when it spreads itself, it then makes more copies of itself. So that's the ideal virus situation. We do see, you know, even if you immobilized everybody for 2 weeks, really you would have to freeze everybody in place for 2 weeks, which is highly unlikely to happen anywhere. You will always have a little bit of those viruses still circulating. So during the flu season in winter, we do see in summer that it goes down, but there are still cases of flu. And in the the more tropical regions, flu is actually an endemic infection. It's all year round. It's just not at a high level like you will see in the northern or southern hemisphere during the winter season. So I know it's you know, it's wishful thinking to hope that all these measures will eliminate some infectious diseases, and it may be the case, but I highly doubt it. I think they're here to stay for a while.
Okay, so I have more questions, but I want to also give the possibility to our participants to ask questions. And a question comes from M. I don't know, our participant M. And his question is, he feels tired, has headache, diarrhea, some fever and muscular pain. Does he or she needs to be afraid?
Well, not afraid, I would say, assume you have COVID, assume you're infected. At this point, you know, what's terrible is that we're all also becoming paranoid. What would have been previously, oh, I think I have the flu, I have a cold, I'm just going to stay home, and we didn't really freak out about it. We just assumed we were sick. Now we're more worried because we know that there's a percentage of the population where it becomes highly severe. But you have to think it's probably, if we do all the numbers correctly, it's probably 1% of the population that's infected that would have severe symptoms, where it would really become a respiratory distress kind of disease. So if you're, you know, and I know we say if you're young and healthy, you probably are less likely to get a severe disease, but we have seen cases. I know in New York City, 40% of the severe cases have actually been people who are under 50. So it's no longer the pattern of people who are much older with comorbidities that are getting very severe disease. We are seeing now a much wider diversity of individuals that are getting it. But if you have all those symptoms, really the thing to do is to stay home and try to distance yourself more from others, and just to assume that you may be infected, and do this for 2 weeks. And of course, if it becomes where, you know, the only time at this point, because it's so severe, especially in the New York area, because it's so severe at this point, only if you can't breathe, if you're really getting respiratory distress, that's the only time you should try to go to the hospital. Otherwise, it would be a detriment to yourself and to others to step out.
Okay, thank you very much. And
real quick,
thank you very much for your question. And I'd like to encourage other participants, whenever you have a question, please write it in the group chat. Yes, Brendan.
I was just trying to follow up to that question. My understanding is that many doctors are offering telehealth now, meaning that you could essentially phone a doctor. And obviously they would potentially advise as to whether you should try and get a test or whatever, right? Is that?
Yeah, so that's absolutely right. Actually, my husband's a doctor, and he's been doing telehealth, and he talks to a lot of patients who are saying, you know, I have these symptoms and here's what's going on. And, you know, the issue right now is you cannot get tested in New York, like you cannot get tested in many places in the US. And that's because, initially it was an issue with the actual tests, then it became an issue with the actual reagents to perform the tests, then it became an issue with the actual protective gear that doctors need to wear to be able to do the test. And then it became an issue with the actual people who can process the samples to get the test. So now there's been a sort of an edict that in New York State, only people who are inpatients, so they're really severe disease, they're coming in, they can't breathe, they're the only ones who can get tested, and some and not all healthcare workers. So even many healthcare workers, nurses, doctors who have symptoms that resemble COVID cannot get tested. But the ones who are working at the front line, the ones who are interacting with sick patients who have symptoms of COVID, they're the one being tested. So it remains a big issue. This whole story of testing is a big, big issue still.
So what are the reasons that USA is lagging behind, or the entire world, is lagging behind the entire world, and the entire world is lagging behind in testing?
That's a very good question, and I don't even know how to answer that. I think one issue that I've observed is the fact that initially, very early on, what was an issue is that the test that was developed, so when this outbreak occurred, so first China did not report it early enough, sadly. They took many weeks to report it, and when they did, there were groups who decided, oh, this is important. So in early January, so this outbreak occurred in early December, and it was reported end of December, early January. So it's sort of the timeline. So there are groups that decided, well, we should have a test and develop a test for it. And a company, a guy in Germany decided to develop a diagnostic test, because you have to develop a test to be able to diagnose it. And tests are very finicky, and they have to be specific enough that you can capture all the positive cases and not call a negative case positive, but you don't want to call a positive case negative or a negative case positive. So tests are a little difficult. Now, that test that was developed was adopted by WHO, so the World Health Organization, right away. At the same time, the Center for Disease Control in Atlanta, here in the US, developed also a test. And that's what the CDC does, is that they do develop a lot of these tests. And what the CDC does often is they have teams that go into outbreak areas and evaluate the situation. But China did not let the CDC go into China initially. And also the CDC had developed a test that did not work very well. And so the next step should have been to adopt the test that was used in the rest of the world and by WHO, but that's not what happened. So they decided then to have companies help in the development of tests. And it's a really complicated story, and I don't know all the political issues behind it, but the conclusion is that we were behind in getting efficient tests. And then when companies got involved, so initially it was only one platform that could be used for the test. Then we were told, okay, a different platform could come in. That means a different company could also try to make enough tests for everyone. And if we go back to the CDC, they usually develop a test, but they don't necessarily manufacture it in the millions. That requires a buy-in from companies. And the US is set up that there is no real centralized organization that takes care of things like that. So if you need to rally companies and say, okay, everybody, we need to have production of massive numbers of kits, to get everybody on board. It's more, you know, whether the companies want to do it or not. And so that is the error in what happened. It's a comedy of errors that has happened. First, a deficient test, then an unwillingness to get everybody on board together. And so what happens in public health, you know, tragedies like happen right now, you need to have a centralized voice that says, okay, everybody, this is what we're going to do. And instead, it's completely diffuse. So if I may go back to even the protective gear and the masks, it is amazing that a country like the US cannot have enough masks for their doctors and their healthcare providers, the nurses and everybody in the hospital, and that we have to have companies that, you know, will say, okay, we'll make masks, but nobody tells them you have to make masks. So there's a huge deficiency in masks right now, and it's amazing. And so it is a problem of not having a centralized voice that tells us what to do, and it should come from the federal government. And right now the response has been at the states, and the states have been competing between themselves for the same resources. And so if we had a centralized voice, we would be told, okay, there's a huge outbreak in New York State right now. We need resources there. Because, you know, don't be fooled. We may not see outbreaks in some parts of the US, but it will come. It's just a few weeks behind. And all those resources that we're bringing to New York, eventually in New York, it will wane, and those resources can be moved somewhere else. I know it's a very long answer to your question, but I think it was an important question to answer clearly.
Yes, actually, it's a very clear answer. And because we moved to New York State and New York City, I'd like actually to ask a question about New York State and New York City. Why New York City, and we are right now in New York City, could be the worst area for coronavirus? And I'd like to show you a graph that I recently saw. Can you see my screen?
Nope, not yet.
Not yet?
Well, it says screen sharing, but I can't see your screen.
Okay. So then I'll not share it, but I'll just describe what's in that graph. That graph actually shows a comparison of different cities in different periods of time. So for instance, after 5 days, after 15 days, after 25 days after the first death. And it compares New York, Catalonia, Ile-de-France, London, Washington. And in the 7th day, New York City has the most deaths compared to all other urban areas. So the question is basically, how come? How come it is possible for this to happen?
Oh, there you go.
Oh, you see the graph, yes?
Okay, so here, let me put my glasses on. So one reason also, so I see you have Washington and New York, right? In your graph, you have California and all that, and then you have Madrid. Now you can see that Madrid and New York follow a little bit the same angle, okay? Now, New York is one of the most dense, population dense city in the US. So it's not surprising that in very dense cities, you are seeing far more transmission and you will see more deaths. That's just what happens. Now, in the actual numbers of testing, so if I take just the US, so we are seeing, for example, that in New York, the number is the highest. And it's true that it's very high, and that, but we also have done far more tests in the US than we've done in other cities in the US. And so there will be soon, probably these other cities, if they tested more, they would see more cases, but they're not as dense in those other cities. And so you can see that in Spain, which is basically undergoing exactly what's going on in Italy right now. So we see it in Spain. And we see it in New York, and they follow a lot of the same line. Now in Ile-de-France, they have been doing far more distancing than we have. So until 2 weeks ago, people were still going to bars, to restaurants in New York. And even, you know, in the last few days, although we're all stuck at home, working at home, if you go to the parks, if I go to Washington Square Park, it's really densely packed. People are still sitting together. If you go on the Hudson River Park, people are completely packed together, and they're basically perpetuating the transmission of the virus. So although we feel like our city is sort of closed down, it's not really. People are still moving around and transmitting the virus. So that's what's going on. I think in many of these cities in other parts of the world, they've done a complete shutdown where people are not allowed to congregate even in public. Now you can go outside, you should not congregate in groups. And so that's part of the issue of what we're seeing in New York. I can't hear you, you're muted.
What can we do in order to overcome this issue in New York City?
Yeah, so I think, you know, the problem is it's hard. I've seen cops go around and blaring, you know, separate, social distancing, you know, but I don't think that really helps. I think people are starting to realize more and more. Now, if you're a news junkie, you would be totally aware of this, but I know a lot of people say, oh, I just don't listen to the news. And in fact, if you don't listen to the news, or don't go on social media, you may feel like nothing's really going on if you're not affected directly, if none of your friends are sick. And I think with the death toll now climbing, now everyone will know someone who's really, really sick. And I think that's the only time people will realize that this is no joke. And so as a point, you know, the issue I bring up sometimes is the fact that in public health, what we try to do is prevent, right? So when you're a doctor, you know, in medicine, you try to cure, but in public health, you try to prevent. And the problem with public health is that when you do impose public health policy that is very stringent, and if it works, people will say, well, you see, nothing happened. Yeah, because the policy worked, but they'll say, but you see, there was nothing really going on. So you lose either ways, because we still have a large portion of the population, even in New York City, who do not believe that this is real, who don't believe that it is as important. And it's also because we do hear, you know, in the news that some people will say, oh, the flu is much worse every year. No, the flu is not worse. It is worse in numbers of people who die, but simply because we take it on a very short time frame, while this is still climbing, and we are not at the end of our season of coronavirus. We are not at the end.
So this naturally goes into the next question. When we will see, if not the end, at least a kind of a controlled situation?
Okay, so you keep on hearing about flattening the curve, right? And so the controlled situation in what is going on now is, so here's what we're aiming for. So how you control an infection like this is with vaccination. That's the only way you could control. A vaccine is unlikely to be on the market and ready to vaccinate a large population until, at the earliest, if it all works well, would be 12 months, okay? So over those 12 months, the whole population could be infected in theory, right? So what you're trying to do is to slow down the number of transmission events. Because what you want, if we forward, let's go forward 12 months or 16, 18 months, and let's assume we get a vaccine and everyone gets vaccinated, or at least a large portion of the population gets vaccinated. So then most people would be protected or partially protected, just like the flu vaccine may not prevent you from getting the flu, but it may prevent you from dying from the flu because it partially protects you. So then what happens is that you get what's called herd immunity. That means many people are protected. That means the ones who are not vaccinated have like a wall of protection with these people. So if someone is infected, at least they cannot transmit to all the immunized people, and it doesn't go into the person that is susceptible because not vaccinated. So what we're aiming for right now is to slow down the transmission so that we don't get too many people infected at once. And the reason is that if you get everybody infected at once, you get a very high number of people who end up in the hospital, and the hospitals cannot take in that many individuals. So if we flatten the curve, people get infected, then you have severe disease, they go to the hospital, they get treated, they don't die. And then, more people get infected, same scenario, right? And also what you do when you what we're trying to do right now is to prevent more transmission so that now we can do what the Chinese were doing, what Hong Kong did right away, what South Korea did right away, and what Singapore did right away was called testing and isolating. So you basically have an outbreak, and what you want to do is test for these people. Are they positive? If they're positive, isolate them. You separate them from their family, separate them from others. Then you continue testing, isolating. This way you don't get what we got here. We ignored that there was going to be an outbreak. We were told there was going to be an outbreak, and it was totally ignored. And now it's too late to do the testing isolation. What we have to do is freeze everybody in place, then slow down the transmission. And once we see it slowed down enough, then we can start working again and do the testing isolation until we get the vaccine in 12 months. Does that make sense?
Yes, thank you very much. And I'll move to a question from Dave. Dave actually asks, do you become immune after being infected?
Dave, that's a very good question. In theory, what we assume is that you do, that you would be at least immune to the strains that are circulating now. Now, the coronavirus does not evolve as quickly as influenza. So influenza, we have to change the vaccine every 2 years because the virus evolves. I mean, it's still the same virus, but it has a slight different flavor so that your immune system sort of recognizes it, but not enough to completely protect you. This coronavirus will probably not evolve as quickly. So we think that, for a vaccine, that's more hopeful. It will evolve, but it will take a while. So it's possible that a vaccine will protect you for a little while. And we think that if you've been infected, you may be protected. Now, there have been anecdotal reports that people appear to be infected again. What we think may have occurred is that, in fact, they were infected and were still shedding the virus. That means they were still, transmitting virus and still having virus replicate, even if they didn't have the symptoms. And that even can happen with flu. So I don't totally believe the reports that people got reinfected. And there are now treatments that are being tested to see if the blood, the antibodies from people who were infected, have built antibodies, and now they're taking these antibodies, the serum from these individuals, and they're testing them to see if they could be protective for people to help cure them from coronavirus. So it's still very experimental, but there is that going on. So the short answer is yes, we think you could be partly protected if you know, if you've had it, you would be immune.
And the next question comes from Brandon. And the question is it true that CPAP machines can be used as makeshift ventilators?
No, it's not true. So that's the CPAP, right? The CPAP is for people that have trouble breathing at night, that have sleep apnea, where they stop breathing in the middle of the night. So this is a machine that basically will push air so that it forces, so sleep apnea is basically where you have parts of your throat that basically closes so that you have trouble breathing. You stop breathing in the middle of the night without realizing it, and then you'll start breathing again, which can be very difficult because you lack oxygen, and often people will wake up in the morning completely exhausted as if they hadn't slept. But the CPAP machine, the problem with it is that it forces air in, but it's not set up for something like an infection, like a respiratory infection like this, because what it would end up doing is aerosolizing the virus even more. So it could actually cause even worse transmission. And so they have looked into the CPAP and the BiPAP as makeshift ventilators, but no, those are not good tools for that. What they are doing is people have been hacking the ventilators to basically do these splitters where one ventilator can be used on 2 people or on 4 people using one ventilator. Now, these ventilators have also these filters, these HEPA filters that will prevent the virus from basically disseminating in the air. And that's the issue with the CPAP also, is that you don't have these filters. So there are ways that people are trying to hack some of these machines, these ventilators, to get more with what we have in hand.
Thank you. And we'll have 2 more questions. And the next question is, what makes coronavirus so resistant? And the BBC, I've read an article from BBC, and it states that some studies of other coronaviruses found that they can survive on metal, glass, and plastic for as long as 9 days. 9 days. And another article recently published in the New England Journal of Medicine states that the virus could survive in droplets in the air for up to 3 hours after being coughed out into the air. So what makes this virus so resistant? And comparing it to influenza, is it the same situation with the flu, or the flu virus acts differently?
No, so both flu and corona are what are called enveloped viruses. So basically you have the genetic information, and it has around what is your virus, it also has like a skin. It's like a layer, a lipid layer that protects it. And so it has this envelope that basically help stabilize it. Now, flu also can survive for many hours on a surface. They're not considered super, I mean, you know, a few hours in the air is not actually that long, and it depends. So the study you report, the New England Journal of Medicine study, they were aerosolizing the virus so that you would have a fine mist. And so that can, basically the virus can survive in fine mist. And they were doing it with an instrument to do this aerosolization. Now, what often happens with flu and corona, when you cough, you basically have water particles, and the virus is in water particles, and that will drop very quickly, but it can also survive within these droplets for a few hours. On surfaces, the New England Journal of Medicine study had also determined that on surfaces, it could survive on steel and on plastic longer than on cardboard, for example, because on cardboard, it can be absorbed. Now, you know, as soon as, the reason we say use soap is because the soap will destroy that lipid layer. And when it destroys the lipid layer, the genetic material, the RNA, it's an RNA genome, not a DNA genome, the RNA will degrade, and RNA degrades very easily. So that's the reason the lipid layer is really protecting the virus, and that's the case for all envelope viruses. So they all survive for many hours, and I don't know how extensive, I'm sure there have been extensive studies on flu also, and I suspect you would find very similar survival times with flu as for corona.
So actually we have two more questions, and I also want to ask the third question. Maybe like shortly I'll tell you and you can answer them together. So the first question is from Dave. He says that his mother-in-law was told her test will take 7 days for results to show up. Is it happening faster in other countries? So this is a question. And another question, is there any result in New York City since the city started the use of chloroquine?
Okay, so your first question was, I'm sorry, was it the testing, how long the testing takes?
Yes,
Yeah.
If it's only in US 7 days, I mean, if it only in US 7 days, but in other countries it's faster or not?
Yeah, so that's a really good question. So here you can get your test within 2 days, 2 to 3 days, and I think the 7 days is because of the backlog. Now the testing is being done. The most specific and sensitive test is called a qPCR test, where they basically measure the number of RNA molecules that you have. And it's an amplification test. It requires, it's this kit we were talking about. So it can take, in fact, if you only had one sample and you were running it, you could have a result in just a few hours. But because they're running things in batches and it takes a while, they have to do all kinds of steps to extract the RNA, etc. So it is the most sensitive test, and it will, it has lower false negative results, and that's always an issue when you have false negative, because you think you're negative but in fact you're not. But in other countries, I know in China and even in South Korea, they've been using also a test that measures some antibodies that you have that are basically triggered early on in an infection. And so it's far less specific. So it could be that it's a false positive that you may get, but that test can be done in just an hour, and it's in blood. So the virus does not go in the blood, but it measures sort of your response to a pathogen. And so it will measure something you have in your blood that's part of your immune response. And that's what they've been doing in a lot of countries. Now, they're also doing the qPCR tests. And often what happens is that they'll confirm, if they get these rapid tests, they'll then confirm them with the PCR test to make sure they're true positives. And what was your second question? It was a good question.
Is there any result in New York City and the city? Mm-hmm.
The chloroquine. Okay, so here's the thing with chloroquine. So the drug that's actually talked about is hydroxychloroquine. And so chloroquine is a drug that's been used for malaria, and that's no longer used for malaria because the malaria parasite has developed a lot of drug resistance, and it's resistant to chloroquine. Now, the chloroquine group, the hydroxychloroquine, is used by people who have very severe autoimmune diseases like lupus or rheumatoid arthritis, where they basically have very, very strong inflammation, and it basically destroys their joints and can destroy their organs, and it's really bad. And so they're on a regimen of things like hydroxychloroquine to control that very severe inflammation. Now, hydroxychloroquine, so that group of drugs can have been tested against a lot of viruses in the lab. And so the way they do that is that they take cells, like human cells or any kind of mammalian cell, and then they'll infect the cells with the virus, and then they'll try the drugs. Okay, so that's done what we call in vitro. And they've seen, the the viruses die. But they've seen that for many viruses. They've seen it for the flu, for coronavirus, and it's because what the drug will do is prevent the virus from replicating, because there's a step when the virus enters the cell where it needs to do something so that it can make copies of itself. And the drug will change the acid composition in the cell and prevent the virus from doing that. But in humans or done in animal studies, it hasn't been very efficient. And there has been one study, and I want to look into other studies that are coming out now, but there has been one study that was very badly done, and it wasn't powered correctly. And when we call power, it means you have to have enough numbers that statistically the number means something, and it did not. They basically played around with the data to show what they wanted it to show. And so it's not a drug to take if you have no symptoms. Even if you have a cold, even if you have trouble breathing, you would not take this drug. I think there are tests, clinical trials being done in France, and it's very controversial in France right now. People want to use this drug, but the tests are just not in yet. So I think the hydroxychloroquine, just like other antiviral drugs that look like they're promising, I think there are 4 or 5 right now, are all being tested in trials, and we should get the first results of these trials in about a few weeks. In April or end of April, we'll know more. But do not go and get hydroxychloroquine, because in fact, that drug, it can have secondary effects that are really strong. It can destroy your kidneys. It has interactions with a lot of other drugs. It can destroy, it's very harsh on people who have heart diseases. So unfortunately, the president has touted this drug as something that we maybe should be using, and he's wrong. He's dead wrong. And actually his words are criminal, because people will die because they are taking hydroxychloroquine, and people who need the drug to survive, like the people with autoimmune diseases, now cannot get the drug because people have rushed to get it, and they will die also. So that's me on my soapbox.
And the final question is, what important question we didn't ask? And what is the answer to that important question that we didn't ask, but you think we should have asked?
So, I mean, your questions covered a lot of things. There are a lot of things you didn't ask that I'm glad you didn't ask. And I think I touched on, I mean, one thing that I've been hearing is people saying the virus is mutating constantly, but you asked it indirectly. And when you talked about, whether we're immune or not. So I think that's an important question, don't worry. The other thing is, I know social distancing totally sucks, but in fact, it is the best tool we have right now. If you want to protect others, this is the one time where we're all in it together, and we're doing it not just for ourselves, but for the others. And so this whole social distancing is the only tool we have right now to control this. So we have to take it seriously.
Okay. Thank you very much, Professor Elodie Ghedin, for the fact that you came today and we spoke with us. And we appreciate a lot this. We will send this message. I mean, whatever we learn from you, we'll send this message further, because many of these participants that are present right now and that will see this discussion with you are actually community leaders. And let me still ask you the following question, because I mean, this is important. What can we do as community leaders to prevent, decrease the infection? Only promote social distancing, or can we do something else?
So at this point, I think the social distancing is the best thing. You can have people, get them to understand. You as leaders can really tell them to take this seriously. You know what? if, you know, a lot of people think it's an overreaction. It's not. I can tell you from a public health standpoint, it's not an overreaction. As a virologist, I can tell you it's not an overreaction. We were actually due. We've been saying every year, we're going to get a pandemic soon. We're going to get a pandemic soon. And so really the best message is for people to take this seriously and to really clamp down on trying to get together as groups. It's not fun right now, and it you know, it'll be a few weeks, and people just have to be really patient, and then to basically reach out to others, because it's very isolating for many people now to be either alone or alone with one person at home. And so to really reach out to everybody, to make sure that they know they're not alone, and that this is for the greater good. If there's anything you're going to be doing in your life where you feel you're making a difference as an individual, it's now. Now is the time. What you are doing will impact others, and indirectly you may be responsible for helping people live or leading to their deaths, sadly.
Professor Elodie Ghedin, thank you very much. As Andrea wrote me in the chat, thank you very much for your authenticity and for being with us. And we'll keep in touch through email and maybe through other means as well.
Great, wonderful. Thank you for inviting me to do this. Thanks.
Thank you very much.
Thank you very much.